I'm thrilled to be here today to talk about the private health insurance side of this equation. I come from Washington, D.C. In our city/state, private health insurance under the exchange is not a very huge issue because we have a lot of large employers and we have a very large publicly insured population. In California, in sharp contrast, you have a huge uninsured population who will be coming through the door looking for private health insurance. So my focus here today is to tell you a little bit more on the private coverage side of California's Affordable Care Act. I'm going to go through a series of questions and hopefully give you some clear first looks at this. The work that I have done has been generously supported by the Packard Foundation for Children's Health. I have been asked to look at the benchmark product in your state, so I've looked in very great detail at the certificate of coverage, your state mandates, everything that one needs to look at to get a good sense of how the private insurance picture is going to play out for children. I've looked within the 10 essential health benefit categories. I've looked at 48 services important to children. These services were identified based on recommendations from the Academy of Pediatrics and from the Children's Dental Project. I recently did a somewhat similar project for the Academy of Pediatrics, so I think these are critical issues for all children, but especially for children with special needs. So today I'm going to give you some of the preliminary findings. In about a week to 2 weeks, I'll be submitting my final report to Dr. Shore and Dr. Alexander. So as you know, the Kaiser small group HMO product was selected as California's benchmark plan. And in contrast to many other states, California has gone on record prohibiting insurers from making benefit substitutions, which is really important and really good. The exception is for prescription drugs. California also did a very good thing. It prohibits insurers from imposing treatment limits that exceed Kaiser's benchmark plan. So, and then this benchmark plan is what people call as a reference plan for products sold inside and outside of the market. And many of us in Washington and across the country feel that this is going to be the pathway for employer-sponsored plans in the future. So it's really important for all of us to look at what's coming forward. So like most small group plans, Kaiser's benchmark product did not cover habilitative services, and it did not cover pediatric dental and vision services. These are two of the required essential health benefits. So the state defined habilitation to be in parity with rehab. The state defined pediatric dental care to be covered as it does in healthy families under its dental benefit. And the state decided the pediatric vision care services should look like the federal vision plan called Blue Vision. In addition, you have several mandated benefits that are relevant to children and adolescents, and I'm just pulling those out. Asthma and diabetes treatment and equipment and supplies, FDA-approved contraceptives, PKU testing and treatment, mental health parity, and behavioral treatment for pervasive developmental disability and autism. So my first question was, how well does Kaiser's benchmark plan meet the needs of children and adolescents with special health care needs? My answer is very well. I think Kaiser offers a broad set of covered benefits for children and adolescents, mostly without visit limits. Kaiser, as many of you know, relies on prior authorization and medical necessity decisions to make its cutoffs. But I think that the scope of services covered are very broad. Certain services in particular, the preventive care goes beyond ACA requirements. The mental health and substance abuse services offer a continuum of care. The rehab, home health, and skilled nursing facility care covers much, much more than most small group plans cover. Not like Medi-Cal, but much better than most small group plans. So I think it's important to keep in mind that small group plans typically set very restrictive limits on ancillary therapies, home health, and fail to cover services that are in your plan, such as intensive outpatient care or residential treatment for mental health and substance abuse disorders. The second question is, are there particular services important to children with special needs that are going to be limited or excluded from the benchmark plan? And yes, there are a few benefit exclusions. They are family therapy, so you've got individual and group therapy covered, but not family therapy. Hearing aids are not covered, cochlear implants, no, and inpatient treatment beyond detox for chemical dependency. There are also a few benefit limitations. Intensive outpatient or partial hospitalization and residential treatment for mental health and substance use disorders are covered only on a short-term basis. Home health care is covered up to 2 hours per visit and up to 3 visits per day for 100 visits per year. Again, this is much more generous than most small group plans. Skilled nursing facility care is typically not even a covered benefit in small group plans. So this is covered up to 100 days per benefit period. So I think in sum, California made a very good choice in selecting the Kaiser small group plan as its benchmark product. Next question is, what differences in out-of-pocket payments will families in platinum, gold, silver, bronze, and catastrophic plans face? So there will be huge differences in out-of-pocket payments for families who do not qualify for cost-sharing subsidies. So looking at what they call these actuarial values, at the most generous end, you've got on average a family who's going to be paying 12% of out-of-pocket. This is on average. You drop down to the catastrophic plan, which is a plan that's going to be offered to 19 to 30-year-olds. You're going to pay 40% out of pocket. So let's drill down a little bit more on the cost-sharing differences, and I'm only reporting here about family deductibles and family cost-sharing, not individuals. So the deductible differences in the let's just call it the richer plans, the premium and gold plans will have no deductibles. But you drop down to the silver plan, and for certain medical services, which are going to be typically hospital services, both in and outpatient and ER services, you're going to have to pay a $4,000 deductible. And you're going to have to pay a $500 deductible for brand name drugs, not for generic. In the bronze plan, a family will have to meet an overall deductible of as much as $10,000, which apply to all services except preventive care and 3 ambulatory care services, so 3 doctor visits. So that's a lot of money to come up with up front, okay? Then think about the person, the young adult or the older adolescent or the parent who's purchasing this for their child who goes into a catastrophic plan. They're going to have to pay $12,800. If they're a family, if they're an individual, it's $6,400 before that they get coverage for anything but preventive care and 3 primary care, ambulatory care services. So then let's think about the good news. At what point are you going to no longer have to pay anything out of pocket? This is your kind of, the real insurance kicks in after $8,000 in the most generous plan and in the other plans at $12,800. So now let's look a little bit deeper down at some of the copay or co-insurance visits in the richest plan versus the cheapest plan. I'm not putting up catastrophic because it just is worse. So from the ambulatory care standpoint, you can see that when you go to a doctor, a family under that plan would pay $20. In the bronze plan, they would pay $60. For the specialist, $40 versus $70. Emergency care, again, this is a really bump up I'm seeing in terms of private insurance. Even in the best plan, you're going to pay $150 copay versus $300 in the bronze plan. Look at inpatient hospitalization. It's $250 a day. You pay that up to the 5-day or 12, if you were hospitalized for that long, $1,250 versus 30% of your hospital bill. Outpatient hospital fees, every time you go to see a pediatric subspecialist at one hospital, you're hitting $250 for your copay, and that's in platinum versus 30%. Okay? So now let's look at your lab tests. $20 versus 30%. You have to get a CAT scan. $150 versus 30%. Okay, rehab services, therapy services, $20 versus 30%. Prescription drugs, generic, $5 versus 25%. Preferred brand names, 15 to 50%. So you can see the story here is not a benefit story, it's a cost-sharing story. So, to what extent will families who qualify for cost-sharing subsidies be protected from high out-of-pocket costs? So, as Meg said, as you know, quite a bit of protection will be available for families who have incomes between 100% and 400% of poverty. There will be premium tax credits, there will be cost-sharing subsidies, and there will be out-of-pocket spending limits. So let me just walk you through a little bit of those in real terms. So if you're at the lowest income level, 100 to 150%, you will have no deductible whatsoever. But look at the 200 to 250%. You have a $3,000 deductible for medical. And again, keep in mind that's mostly hospital services, inpatient, outpatient, ER services. And you're going to have to meet the $500 deductible. So that's a lot of money for somebody who's got, for a family of 3, that's an income between $39,000 and $49,000. It's a lot of money. So when you think about, again, your out-of-pocket maximum protection, nobody at the 100 to 200% will be spending more than $4,500 for covered services, but $10,400 for the 200 to 250%. So it's not, it's not Medi-Cal. It's not Medi-Cal. So now look at your copays. What I did here is from the lowest income to the 200 to 250%. So I'm at 100%, I will pay $3 when I see my primary care doctor. I'm at 200%, I'll pay $40, okay? My specialist goes from $5 to $50. My ER goes from $25 to $250, but first don't forget I gotta meet my deductible, okay? So hospitalization, 10% versus 20, and again, for the 200 and 250, you got a deductible. Generic drugs, $3 to $20, brand name, $5 to $30. With a deductible, don't forget, of $500 that you have to meet. So clearly, you've got significant subsidies, but you can see that at 200% of poverty and over, it's significant. It's, you know, you're not uninsured, but boy, you're paying for care. Okay, so then I looked at, well, what now? The state made its decisions about its benchmark. It made its decision about how much the cost sharing is going to be. So now it's going out to bid to qualified health insurers. So what did they tell qualified health insurance about children? And what should be included about pediatric provider networks? So although in the introduction of the RFP, the state recognized California's history of multi-specialty and organized medical groups, there was little or no mention of this included as a specific requirement. The RFP emphasized the importance of contracting with providers and networks that have historically served low-income and uninsured populations. And they go on to talk about you have to document your involvement of essential community health providers. So, and those they define as community health centers, rural health centers, county hospitals. There's no mention about regional centers. There's no mention of CCS networks. In addition, the RFP emphasized provider network adequacy, yet there was no requirement for identifying the PCPs and specialists with pediatric certification. The RFP emphasized quality improvements and had an enormous amount of requirements around pediatric and adult performance measures that are HEDIS measures, very typical for most managed care companies. The RFP also emphasized innovation, and they defined that to focus on medical home, quality improvement, patient engagement, and community prevention. But so in sum, the California solicitation offered few pediatric-specific requirements. So where does that leave us? I have some suggestions from a policymaker's perspective and from families and providers. On the policymaker front, I think it's very important now for certain children who qualify as being quote-unquote medically frail, which the state has to define, they can be exempt from private coverage and go into Medi-Cal. So I think it's very important that policymakers work with CCS, the state AAP chapter, your chapter for the American Academy of Child and Adolescent Psychiatry, to establish a clear definition of who are medically frail children who will be exempt from benchmark coverage. The second recommendation I have, I think it's really important that the qualified health plans that will be offering coverage, there has to be close examination that they have really adhered to Kaiser's benchmark plans. I don't think you can assume that's an automatic. I think it's important that there be a mechanism to look at the qualified health plans' prior authorization and medical necessity standards for children's care, particularly since there are no visit limits. These are going to be the defining decisions. I think it's also important that policymakers look at the pediatric provider in-network services, including CCS providers and child and adolescent mental health providers, and also the formulary relevant to qualified health plans. I think it's very important that there be a mechanism in place to coordinate the CCS benefits and inform providers and families providing so that they can get easy information about this linkage and also about their cost-sharing obligations. In addition, I think over the next 2 years it's going to be an important period to monitor access to care and experience, particularly given these high cost-sharing amounts. And looking at it not only from the family's perspective, but from the providers they serve. I mean, there's going to be a lot of bad debt rolling around the table. I would think it would be awesome if the state would consider forming a children's ACA advisory group to assist in these recommendations, looking at formularies, looking at prior authorization, monitoring access to care, looking at provider adequacy and quality improvement. Finally, from the perspective of the families and providers, I think it's very important that we inform families who may qualify as disabled or medically frail or as some special group of their exemption from mandatory enrollment in benchmark plans. I think it's critical to encourage families, if they are able, to purchase platinum or gold plans, just no question. Informing families about the cost-sharing liabilities they will face in silver and especially in bronze plans. Informing older adolescents and young adults and their families about the cost-sharing liabilities in catastrophic plans. And finally, encouraging families to find out about participating provider networks, noting the difference between what will be the cost-sharing requirements in the different tiers. So I only told you about what's for an in-network, but let's just say you go to the second tier of in-network, or you go to a provider that's out of network. I mean, these are critical things that will make huge financial decisions. So in that closing remark, I think there's some very positive things that the state has done, but there's a lot of things to look out for in the future, and I wish you well. Thank you.